Oh, they don't see the slides yet. Oh, I didn't start. Oh, they started. Maybe they did. Can you guys see the slides? Can you guys see the slides? Yes, okay. So I'm gonna go ahead and get started because the talk is long and the topic is very complicated. So today I'll be talking about the antiphospholipid antibody syndrome and what I learned. Oh, sorry, this is the fog. And what I learned about it is that the more I tried to learn, the less I knew. I will tell you what I learned, or part of it. I would like to thank Dr. Fasky and Dr. Cohen for their help preparing this talk. And so the whole idea was inspired by a case that I saw when I was a junior last year, early in the year. This is a guy who was 31-year-old with presented with recurrent strokes. So a couple of months before presentation, I called this time 0. He had some subjective intermittent headache and diplopia. Nothing was made out of it. And then 2 months later, he presented to an outside hospital with the right upper extremity dysmetria, numbness, some dizziness, unsteady gait. They did an MRI that showed left pontine stroke, and the vessel imaging showed severe left vert stenosis. They went ahead, since he's young and wanted to work him up, did an angio. And the angio was showed again the vert stenosis and some beating of the left inferior MCA. So they did an LP that was a little bit inflammatory and showed 17 white cells. Otherwise, the protein was normal. And so this raised the possibility of all sorts of infections or vasculitis or other conditions. They sent some labs, including hypercoag panel that was negative, including the lupus anticoagulant and the antiphospholipids. And nothing came back positive on their workup. They did another MRI like less than a week after the first one, and that showed a new pontine stroke on the right side this time, and you'll see the images. They offered him to do a biopsy to try to figure out what this is about, because they were concerned of vasculitis, and they offered to treat him with steroids. He refused, so he was discharged on aspirin and Plavix. However, less than a month after that, like a few weeks later, he presented again with dysarthria, dizziness, and unsteady gait. They did an MRI that didn't show like really new strokes. They were just evolving. But they repeated the vessel imaging, and the CTA was much worse. This time it showed ACA irregularities. The MCA was worse. The basilar was irregular. So what they did is they started him on Lovenox and IV Solumedrol, switched to prednisone, and he left the hospital. This is some of the images from his scans. This is his initial MRI. That shows the left pontine stroke, and then this is less than a week later. It shows a right pontine stroke, and this is posterior temporal strokes, also like a week in the second MRI. His vessel imaging. This is his angio. This is an axial view, I think. Yeah. This is the vert stenosis. It's at the junction of the vert and the basilar, and it was like 90%, very significant. This is the left MCA. I think that's what they call the irregularity. The vessel, the inferior division, narrows down before opening up. And this was seen also on the sagittal view. It goes and becomes smaller, and then there was a few irregularities. And this is his imaging 1 month later. We see that the MCA is much worse. It's very ratty, very irregular. And we see that in other vessels, like if you look at the basilar, we can see how it is, the P1s on both sides. So it's definitely, like, it was clear that his clinical picture was evolving. The gentleman was seen at MGH clinic and actually here as well for a second opinion because he didn't want invasive procedures right away. And he was admitted to the MGH stroke service for workup, and that's where I saw him. His exam was unremarkable, and his imaging was stable compared to the outside hospital imaging. He had been on the steroids and the Lovenox for like a few weeks then. We repeated the LP. It showed only 4 whites. Otherwise, it was unremarkable. His CSF was sent for all sorts of infectious workup. They were all negative. The lymphoma workup was also negative, flow, mutations, after exam, etc. We sent like serological workup for autoimmune diseases that was negative. The only thing that came back was a positive IgG beta-2 glycoprotein 1. And this is part of the assay that we sent for the antiphospholipid antibody syndrome. This is one of the what we call antiphospholipid antibodies. It was positive at 43, which is high titer. And otherwise, the anticardiolipin and the lupus anticoagulants were negative. And this is what I'm going to be focusing on during this talk. What does this mean? The other remarkable thing was that he was having like a little bit of thrombocytopenia. His platelets were 129. And he actually went ahead and agreed to get the biopsy, which they did it in the left frontal cortex because that's where the vessels were mostly affected. Supratentorially, and they visualized multiple vessels, but they didn't see any abnormalities. There was no inflammation, there was no lymphoma, there was no thrombi in the vessels that they got. So this was discussed on chief rounds, and the diagnosis was still a little bit not clear whether this is CNS vasculitis or vasculopathy from antiphospholipid syndrome. Last year, Aaron talked about the CNS vasculitis in great detail. It's a great talk. Maybe you should give it again. And I'm going to try to brush on the surface of antiphospholipid to see what it means if a patient comes in with a stroke and a positive antibody. Is it a false positive, or can we count on it? So what I'll be talking about in the next few slides is define the disease, how we test for it, the pathophysiology. There's a lot of new exciting findings about how these work and cause thrombosis, what we see on pathology slides, and basically how we diagnose it, what are the criteria, the variants. There is the catastrophic antiphospholipid syndrome that's actually like a very interesting entity, and how we treat it. And I will tell you what happened to our patient and how his management was decided at the end. So we all know that this is a hypercoagulable state. It was discovered about like 30 years ago. And that can cause arterial as well as venous clots on both sides of the circulation. It can be existing by itself as a primary entity or secondary to autoimmune diseases, mostly lupus. There is about 30% overlap. And it is caused, it's thought to be caused by, or associated at least, with autoantibodies. Those autoantibodies are called antiphospholipid antibodies. But this is clearly we now realize that this is a misnomer, because those autoantibodies, the more we know about them, is that they're not only antibodies against the phospholipids, they are also antibodies against proteins, and they are a very heterogeneous group. So what we will learn through this talk, what I learned, is that we have, like, let's say the lupus anticoagulant is a heterogeneous group of different antibodies that target different things, including phospholipids, as well as proteins associated with the phospholipids, as well as just proteins that are independent of phospholipids. So we're going to take a closer look at that. It usually happens in 30% of lupus patients. If we screen them, 30% are going to be antiphospholipid positive. And it's like overall in the general population, it's about like 6%. In our population, in the stroke patients, if we test everybody that's less than 45 years old, we're going to find it in 20%, which is like a really high number. And in the population overall, it's about 7%. And most of my talk is going to be focused on this stroke population, guys, because this is what's really most relevant for us. One thing I want to like really emphasize is that if somebody is antiphospholipid positive, it doesn't mean they have the syndrome of the antiphospholipid antibody syndrome, because there's a high rate of false positives. So if you look at the neurological manifestations, I learned that that it's actually very diverse. It can be the result of direct thrombosis, arterial thrombosis, like we can see TIAs in 11% of the patient with the syndrome. We can see strokes in 20%. We can see multi-infarct dementia, migraine, and epilepsy and chorea are thought to be maybe vascular but not thrombotic. Like there's no clots that have been actually identified. So there is different a lot of neurological presentations that can be due to this syndrome. And this is something to be on the lookout for. Another thing is VSD. They're lumped with the DVTs. They occur in 39%, and thrombocytopenia occurs in about 30%. So I'm going to present like really quickly a couple of studies that showed the wide variety of angiography findings in patients with what was thought at the time to be antiphospholipid antibody syndrome. And here, those studies were done before the criteria was set. And the reason I mention this is that the first set of criteria was proposed in 1999, and they proposed a repeat. We need to repeat testing at 6 weeks. That has to be positive. And the criteria were then reviewed in 2006. And this time, it was about they wanted the interval to be positive at 12 weeks. Those studies were done before this required, the criteria of repeat testing was required. So most of those patients were tested only once. But in any case, they were labeled as antiphospholipid syndrome patients. And in the first study, 23 patients who had the strokes, 17 of them had abnormal angiograms. And of those, 16 were arterial, 1 was venous sinus thrombosis. 10 of them had intracranial lesions, and 6 had extracranial. And the TEEs were negative to kind of rule out any cardiac source. What they found in the intracranial findings basically showed any vessel can be affected. The MCA, smaller branches, main stem, basilar. And interestingly, what they found is this vasculopathy pattern in 4 patients. So these patients had diffuse disease, narrowing, beating, and their CSF was normal. And there was no biopsies to confirm if there's inflammation or not, but they were presumed to be vasculopathic. One of them was treated with immune suppression and improved. The other ones were treated with just anticoagulation and improved. Infarcts on CT or MRI at the time were only positive in 13 patients. And I'm just showing here a couple of representative images from these studies. This is a 27-year-old gentleman who had acute left weakness with a positive lupus anticoagulant, and we can see that the MCA, we have an M1 cutoff. There's a clot here. This is a patient who's 56 with connective tissue disease and was thought to have a vasculopathy pattern. She had a lot of irregularities in her vessels, and she also had some cutoffs in some places. Another one showed like a really big vessel cutoff. This is a left common carotid. This is a 26-year-old lady with basically the workup, the TEE was negative and showed this gigantic clot. So it can be anywhere. The second study did something similar. It was a little bit earlier, but they did bigger group. They studied 128 patients, and they tested for the anticardiolipin and the lupus anticoagulant. The beta-2 glycoprotein was not discovered at the time. That's why the tests are only limited to those 2 antibodies. But what they found is that, look at this distribution. They found basically very similar thing. The angiograms were normal in 18, but they were abnormal throughout the intracranial vasculature in all the vascular territories, including the basilar, and this vasculitis, what they call vasculitis pattern in 2 patients. And there was also extracranial lesion. So if we agree that those are antiphospholipid syndrome, the lesion can be smaller vessel, bigger vessel, vasculopathy pattern, can be anything. So the next, I'm going to talk a little bit into how we test for it, because this is a subject that had been caused a lot of confusion for me as to how to interpret the different tests and what does it mean when I see a result. Just very briefly, this is a reminder of the coagulation cascade. We have the intrinsic pathway starting with 12, goes activate 10. This step is phospholipid dependent. And this step is also from 10 to the thrombin is also phospholipid dependent. So this is the intrinsic. This is also relevant for the extrinsic pathway. Eventually, this results in platelet aggregation, thrombosis, and as well as fibrin clots. So this is where our antibodies work on. We think on those steps that are phospholipid dependent. Just a brief reminder as to what phospholipids are. This is the cell. It has a membrane, lipid bilayer membrane. It's formed from like these phospholipids. There is a glycerol and 2 fatty acids, and they can be like choline or serine or different kinds. They interact with the glycoproteins or different kind of proteins in the membrane. Everything is kind of free floating, and so they form different kind of complexes. And so this is a slide I borrowed from Dr. Salmon's PowerPoint that he sent us last year. It actually serves like great purpose. It's like really great for this talk because it shows exactly what we know and what we don't know. There's a big overlap. We see antiphospholipid antibodies in lupus patients. There is like 30% overlap. But what's interesting is that the antiphospholipid antibodies is a heterogeneous group of antibodies. We don't really know what they are. We usually send those two tests, the anticardiolipin and the lupus anticoagulant, and these by themselves are not like one antibody. These are also heterogeneous groups of antibodies that interact with phospholipid, they interact with protein, and they interact with phospholipid protein complexes. So this is very important to keep in mind when we think about those tests and how to interpret them. So we're just screening for a bunch of antibodies that gonna come up positive on the test, and we'll see how this happens. The only one that's kind of specific for one protein, and it's not actually an antibody, is the beta-2 glycoprotein 1. And this is the one that's most relevant for pathogenesis of the clots. We see sometimes it's identified as part of the anticardiolipin test. Sometimes it's identified as part of the lupus anticoagulant. So these heterogeneous groups of antibody, one of these antibodies could potentially be the anti-beta-2 glycoprotein. And sometimes it's like isolated without the other tests being positive. And we'll see why we have this heterogeneity and how this causes a lot of trouble in terms of interpreting the literature. So in general, when we get a patient in the clinical setting, let's see young patient with strokes, we suspect the pretest probability for antiphospholipid is a little bit higher than usual. So we send those three tests: lupus anticoagulant, anti-beta-2 glycoprotein, and anticardiolipin. These two tests, the beta-2 glycoprotein and anticardiolipin, we are testing for antibody. So this is an ELISA test. We're screening directly for the presence of the antibody. The lupus anticoagulant test is a completely different mindset. We're not testing for the presence of antibody directly. It's a functional test. We see, if we look at the coagulation cascade and the clotting time, and we see if it's prolonged or not. And this will be an indirect sign for us, like an indirect suggestion that there is something that's binding to the phospholipids, and we'll see how this happens. But we're not looking, we don't identify an antibody straight ahead like we do in the other two tests. So the lupus anticoagulant, as we said, is a heterogeneous group. Beta-2 glycoprotein was identified as one of those, prothrombin, anti-phosphatidylserine. They're all like being worked up, and those separate antibodies are being identified. It's a misnomer as well, because in vivo, these antibodies cause coagulation. They cause clots. While in vitro, it's anticoagulant. So the anticoagulant nomenclature does not apply for what it does in vivo. And that's where it stems from. It's a functional assay. At MGH and the Brigham, we send two tests. When we send lupus anticoagulant, we basically asking them to screen for the PTT and for the Russell Viper venom test, and we'll see how those works. We usually do both because the sensitivity of either one is less than 100%, so both will give us better sensitivity. So the way they work is that the antiphospholipid, the APTT test is just, we look at the PTT time, the clotting time, and we see that it's prolonged. If the lupus anticoagulant is present, if those antibodies in this entity are present, they're gonna bind to the phospholipid in vitro, and they're gonna basically prevent the coagulation cascade from proceeding. It's gonna cause a prolonged PTT. The same thing happens with the Russell Viper venom. This venom activates directly the factor 10A, and if there is lupus anticoagulant on board, what happens is it binds to the phospholipid, and then the coagulation time is going to be prolonged as well. And I will go into this in a little bit more detail. So each test, when I send this test to like the lab here, I tell them I want to test the lupus anticoagulant. What they take is they do a blood sample. They take a blood sample, and the way they check for PTT and INR, they check for this. This is the same PTT. Let's say it's prolonged at 60 seconds or whatever the value is. They will be like, the screening test is positive. What we're gonna do now is we're gonna make sure that this is not due to an inhibitor, or this is not due, like, is it due to a factor deficiency? Let's say factor 8 is deficient, or is there an inhibitor of factor 8 or factor 5 or an antibody like lupus anticoagulant? So what they do is they do a 1-to-1 mix. They bring the serum from the patient, and they mix it with 50-50 mixture with the serum from a normal sample. If it corrects, then we expect that this is not lupus anticoagulant, this is factor deficiency. And by supplying the factor, we're basically taking care of the deficiency, and then the clotting time will normalize. This is the mixing study. If the mixing study continues to be abnormal, what we do is we want to prove next that this is phospholipid dependent, and it's not due to like an inhibitor of factor 5 or 8 or something like that. So what we do is we add excess phospholipid to the mix. When we add excess phospholipid to the mix, we kind of overwhelm the lupus anticoagulant. We overwhelm the antibodies that are present in the serum from the patient, if he has it, and then we can correct for the coagulation deficiency. So these are required steps: the screening, the mixing, and the confirmation study, to basically say that the patient has this is a true value. This is a true positive test. So we do it for if we see that the APTT is abnormal, and we do the same thing for the Russell Viper venom, the same 3 steps. This is how they do it, and we're required actually to. We're required to do the 2 steps. Either of them is going to give us a positive test. So it doesn't have to be both positive to call it a lupus anticoagulant positive. One of them is enough. Why do we do the Russell Viper venom test? This is the reason is that it's more specific, and we'll see why. It directly activates factor 10. It's a venom from one of the snakes, and converts prothrombin to thrombin in the presence of the phospholipids. So what we do is we get some rate-limiting concentration of the venom with some phospholipids. It's calibrated to give a clotting time 20 to 27 seconds. If the lupus anticoagulant is present, it's going to interact with the phospholipids, and that's going to prolong the clotting time. We do the mixing study. If it continues to be abnormal, then the lupus anticoagulant is present, and it's sequestering the phospholipids, preventing clotting. We do the confirmation, and we expect to correct clotting time. And then they do some sort of ratio. The reason is it is better than the APTT. It's more specific, I would say, is that it's not affected. It acts way downstream on the coagulation cascade. It acts on factor 10A directly. So if there are inhibitors of factor 8 or 9 or 11, that's not going to affect the test. The only one that might cause a false positive is the factor 5 inhibitor. So,
is that true of pregnancy? The Russell's Viper preferred because it doesn't get corrected. It won't give you a false positive as pregnancy will.
I'm not sure. I do not know the answer to that. I did not come across the obstetrics literature. I didn't delve into it, but it's probably correct. We get false positive on heparin, and the reason being that heparin binds to antithrombin and inhibits factor A and the thrombin. And so this will definitely give us a false positive by increasing the APTT. So that's why we cannot interpret this test if the patient is on heparin. Initially, it was thought that we cannot interpret this test while the patient on Coumadin, but that the guidelines have been changed. There's a congress that meets every 3 years on antiphospholipid syndrome, and they changed the guidelines as when it comes to Coumadin testing for lupus anticoagulant and Coumadin. The false positive is actually 24%, and the false negative is 18%. So this is not a great test. The anticardiolipin the cardiolipin is a phospholipid that's present only in the mitochondrial membrane. The way we test for it is by doing the ELISA to check for the antibody. We put the cardiolipin as an antigen, and I will show you how we exactly do that. So this is going to be let's say the plate. This is the cardiolipin antigen. That's how the commercial plate comes. And we pour the serum from the patient on it, and if the antibody is present, we expect it to bind to the cardiolipin. But it's not only an antibody against cardiolipin. Sometimes, because this is a phospholipid that can be found in those assays with other proteins like a beta-2 glycoprotein, if we have antibodies against the beta-2 glycoprotein, the assay is going to be positive. And if we have antibodies against different domains, for example, of the beta-2 glycoprotein, the assay is going to be positive. So this is one example how one assay that's labeled positive for anticardiolipin is a mixture of different antibodies targeting different things. And there are other proteins that interact with the cardiolipin as well. This test is not affected by anticoagulation. We can send it anytime. It still has a lot of false positive. And the last one we sent for is the beta-2 glycoprotein antibody. We mentioned that it's basically present as part of the lupus anticoagulant and the anticardiolipin assays. It was found, identified in 1990s as a cofactor. The antibodies were discovered in 95, and there is a high false positive rate, and we'll see why in that in that case. We test for it by ELISA. And again, this is a polyclonal antibody. We test for different domains, as you saw. It can attack domain 1 or domain 5 or domain 4. So it can be a mixture. So to just summarize, we go back to this slide. Lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein, there's a big overlap. We could be testing for the same antibody that can come back positive in one of them and not the others, just because it's such a heterogeneous mix, and we have a long way to go in terms of purifying those antibodies and testing for them. But the question is, how does the presence of antiphospholipid antibody affect the risk of thrombosis? Let's say I have a patient with a stroke and they're antiphospholipid positive. What is the risk of thrombosis in this patient as compared to the patient who does not have antiphospholipid positive test? There's a lot of literature about it regarding the subject. And the most helpful was this systematic review from this Congress, the Antiphospholipid Congress, that went over 30 studies with 16,000 patients. Those patients were mostly case-controlled studies. Some of them are venous, some of them are arterial. And the way it was designed is that they identified patients with thrombosis, and they saw which ones have antiphospholipid positive, which one have it negative, and tried to risk stratify and come up with odds ratio. The patients who had already the diagnosis of antiphospholipid syndrome, the patients who had 2 tests were excluded, as well as the patients who had autoimmune disease. What's remarkable here is this discrepancy here. We see that the lupus anticoagulant, the odds ratio was 6, so there's definitely associated risk for thrombosis. This is for venous thrombosis. The arterial story is a little bit different. And it was differently significant. There was no bias in those studies. The only other one that was positive was the anticardiolipin. The beta-2 glycoprotein did not show up with this pooled analysis. Not going to go too much into detail. I'm just going to contrast it to the arterial thrombosis. And this is where our stroke patients come. The lupus anticoagulant, all of them now became significant. All of them had an odds ratio that's significant compared to like people who do not have antiphospholipids. So any of them, and we see here that they added other antibodies. Those are not in the criteria yet, but these are making their ways. So for those 3 that we sent for, all of them, the presence increases the risk of arterial thrombosis, and they were kind of close to each other. They're all significant, maybe random as well. There's no bias in the studies. So for our patient, most of these studies, as we said, 28 were case studies, so it was mostly retrospective. Only 2 were prospective. But let's say we have this gentleman, and I have a case on the ward with a patient who had a stroke. We suspect antiphospholipid, we send it, it's positive. The question is this the same as the antiphospholipid syndrome? Is this the same? Like, what's the risk of recurrence of stroke if we look at, if we follow them up over a couple of years? And this study by Levine et al. Did exactly that. So this is interestingly, it's a subgroup analysis of the randomized clinical trial for the warfarin versus aspirin study. So they were studying the effect of aspirin versus warfarin on recurrence of stroke, and then they took 720 patients from this study. They took 720 patients that had strokes and at the same time had a positive antiphospholipid antibody within 90 days. The only 2 antibody tests they sent were cardiolipin and lupus anticoagulant. Beta-2 glycoprotein was not part of this study at the time. And they didn't use a clear cutoffs, and this is one of the major limitations of this trial, because right now the cutoff has to be more than 40, it has to be more than 99th percentile. They accepted anybody that tested positive with the anticardiolipin. So keeping that in mind, what they did is they followed these 720 patients with stroke and positive cardiolipin or lupus anticoagulant over 2 years. What they found is that if they look at event rate, including death, stroke, MI, or TIA, it was basically the same. There was no increased risk. And when they looked at the stroke rate, it was also the same, like about 11%. We see, and so there was, based on this study, with its limitations, there was no increased risk prospectively if a patient comes in with a stroke and positive antibody, which is against what we just saw in the retrospective studies and the pooled analysis that showed increased odds ratio. So not clear how to answer that.
And they didn't recheck them after 12 weeks?
No, this study, no, they did not. But there is other data that I will show you in a little bit that they did check, and you will see that persistence increases the risk dramatically. So
these guys were all on
they were on Coumadin or aspirin, and they basically did the interaction, and they didn't find an effect of recurrence, a difference between aspirin and Coumadin. That's another thing. So this is just to show the 11%, so there was no difference. We'll talk now about the pathophysiology, and I think this is the most interesting part of the talk because I learned a lot about it. The first question that comes to mind is what causes the generation of these beta-2 glycoprotein? And the pathophysiology part is going to focus on the beta-2 glycoprotein antibodies because repeatedly in vitro, this is the one that's causing the pathology. This is the major player. So one idea was this idea that the generation of antibody is triggered by molecular mimicry. It was the reason they suggested that is because this correlation. Like, look at all these kind of infections, and there is a lot of studies that show this kind of high rate when somebody is infected. The presence of lupus anticoagulant or beta-2 glycoprotein, and sometimes the other ones, it's going to be positive 20-30% of the time. So there is this kind of association that was a little bit odd. One of the groups went ahead and took it a step further and studied the homology between the different domains of beta-2 glycoprotein and these viral and bacterial particles. And here, I'm sorry, it doesn't project very well, but we have different peptides that show the highest homology. This is viral and bacterial on the left, viral and parasitic on the left, I guess, and bacterial on the right. We see all these pluses and stars and marks suggest homology. Those are domains from different, those are peptides from different domains of beta-2 glycoprotein, which has 5 domains. So there's a clear evidence of homology. And based on this, they just proposed that its molecular mimicry triggers the presence of antibody that causes it to be present in the blood, either as non-symptomatic or it can cause trouble later on. But this is an idea about the generation of it. The second thing was, what's causing this discrepancy? If we suggest all the time that from the in vitro studies that the beta-2 glycoprotein antibody is what's causing the pathology, why don't we see increased odds ratio in terms of thrombosis risk as compared to the anticardiolipin and the lupus anticoagulant antibody? Because if we remember, the pooled analysis showed similar odds ratio. The pathology is all coming from this antibody. Why don't we see that? And one based on, again, on like studies from the in vitro, it was suggested that that it's domain 1 antibodies that are pathologic. So the beta-2 glycoprotein has 5 domains. These different domains are targets for antibodies that are present in serum. It's only the antibody, or mostly the antibody against domain 1 that's pathologic, and we'll see why. We'll see some data about that. One group sought to validate this in patients and see if we stratify, like at Brigham and MGH, we only sent for the polyclonal beta-2 glycoprotein antibody. We don't send for domain 1. He was like, this group, the lab group, were like, how about if we look at patients that have beta-2 glycoprotein antibody and stratify them if they have monoclonal attacking domain 1 or attacking the other antibodies, the other domains, do we see a difference in risk stratification? So they did a study across different European centers. They identified 442 patients that had thrombosis and beta-2 glycoprotein. What they found is that 243, 55% of those patients had specific domain 1 antibodies, and they found that 83% of those had thrombosis. The odds ratio was about 3.5%. And we see here that this is basically just showing that 83% of the patient that had domain 1 compared to the patient that had non-domain 1, the ratio of thrombosis is definitely different. So the domain 1 appears to be more pathologic. And the odds ratio was 3.5. And now, if we compare it to the lupus anticoagulant, it's actually more, it carries more risk as opposed to the non-domain 1, which seems to be protective here. Not clear why that is. So the beta-2 glycoprotein, 5 domains. Domain 5 binds to the phospholipid membrane. And domain 1 is the one that's free-floating in plasma when this protein is bound to the membrane. If we notice here, this fluctuates between oxidized and reduced state. The reduced state has the thiol groups that basically are there. And when it's oxidized, we have this disulfide bond. The studies from basically in animal models as well as in vitro tissue is that this is immunogenic. The antibody binds to this one, it does not bind to this one. This plays a role in basically, this suggests that there is a role of oxidation, and we'll look into that a little bit. So if you look at the just actual patients with antiphospholipid syndrome, there is higher oxidized beta-2-glycoprotein in their plasma, and they have other markers of increased oxidation, like those markers, the 8-epi, PGF, and stuff. The other thing that was found also is that this oxidized form of the protein is definitely elevated in the antiphospholipid syndrome patients, and the controls group were actually pretty good. The healthy subjects, thrombosis without the antibody, and autoimmune diseases with or without antiphospholipids. So even if they have the antiphospholipid, if they don't have the disease, they don't have as much oxidized beta-2-glycoprotein. This is basically suggesting a role of increased oxidation from insults. And this is the study that shows that if we oxidize the beta-2-glycoprotein domain 1, and this is only domain 1, if we oxidize it, the binding of the antibody is much higher than if we use the reduced group. This suggests selective binding of the antibody, causing the molecular cascade that we're going to see in the next couple of slides. The other thing that's important about the antibody binding is that this glycoprotein exists in a closed form, so the domain 1 is not usually exposed to antibodies when it's in the plasma. When it binds to the phospholipid membrane, this opens up, and the IgG now binds to domain 1 and triggers the cascade that we're about to see. So just to sketch it as a cartoon, and we'll go into more detail next slide, this beta-2-glycoprotein normally in normal subjects, it exists as closed form. It opens up when it binds to the phospholipid membrane, and if it's oxidized, it's going to bind to this antibody. This is going to exist, this complex is going to exist as bound to the membrane and interacts with those receptors and trigger cascades, pro-thrombotic cascades in the different cell lines. Or it can be in plasma and go into different places, like activates platelets or in different platelets in the different places in the circulation. So if we look into this into more detail, with the proposed mechanisms from the different groups is this 2-hit model that we need an injury to the endothelium to start with. And this is based on studies where they take the serum from antiphospholipid patients and they inject the serum in mice, and it does not cause clotting if you just do that. While if you injure the endothelium in mice, the thrombotic cascade kind of explodes more than usual. And so the idea is that you need priming of the endothelium, and that basically set the antiphospholipid antibody up to act and potentiate thrombosis. And as far as the molecular mechanism, we kind of talked about oxidation making the antibody immunogenic, but there's also evidence that increases the annexin 1, and this leads to activation of the endothelial cells. More interestingly, these antiphospholipids, what they do is they reduce the eNOS activity, the endothelial nitric oxide synthase, and what that does is that it prevents arterial relaxation and contributes to vasculopathy or to thrombosis. It also binds to other proteins, like, for example, this complex will dimerize and activates like different kind of kinases in the endothelium and activate it. It leads to overexpression of adhesion molecules, and this will lead to monocytes binding and then activation of the monocytes and production of cytokines. Same thing happens with the platelets. This antibody with the protein, they cause the dimerization. It cross-links receptors that are present on the platelet surface, and this will increase thromboxane and the GP2-3A that's required for activation and propagation. So there's different venues that have been documented over and over again. Some of them also like involve increasing expression of the tissue factor through like NF-kappa B mechanism, and these are all like therapeutic targets. Similar mechanisms on monocytes and PMNs increasing tissue factor. And similarly, we have complement activation. It's not clear exactly how this happens, but we observe that, and that in turn leads to tissue factor. So there is kind of like a feed-forward cycle that propagates the thrombotic state and moves it forward. Another way it interacts and causing more thrombotic state is the interaction with the protein C and plasmin, preventing them from causing the opposite end of the coagulation cascade, putting a brake on coagulation to hinder fibrinolysis. So to summarize the thrombosis mechanisms, we have endothelial, the antiphospholipid antibody binds to endothelial cell membrane, monocytes, platelets. It causes activation through different mechanisms by expression of adhesion molecules, attracting glucosides, expression of thromboxane, tissue factor, activation of the complement, inhibition of plasmin, protein C, and this all leads to thrombotic state. But the more interesting part is actually this one. What causes vasculopathy? What causes long-term changes in the vessels? What causes hyperplasia of the endothelium and deposition of collagen to cause this vasculopathic pattern that we see with antiphospholipid and vasculopathy in different organ systems? And this has to do with the mTOR pathway. This study did I thought it was really well designed, a genius idea. We'll see what they did. They had some evidence from in vitro tissue assays that the antiphospholipid, when it binds to beta-2-glycoprotein, activates the PI3 and mTOR pathway. This mTOR pathway is usually, it wasn't clear to them if it's clinically relevant, but what they thought about is that the mTOR is a target of sirolimus, which we use as an immune suppressant after organ transplant. So let's see if patients who have organ transplant and have antiphospholipid syndrome that are treated with sirolimus, do we see any benefit from that? And they had the population to study ready for them because they looked at the kidney transplant patients. It's very well known that the antiphospholipid syndrome causes kidney vasculopathic nephropathy. It causes all sorts of chronic modeling of the vessels in the kidneys. And so these patients end up getting transplants and getting treated with different immune suppressants. Some of them get treated with sirolimus. And so what the hypothesis was that is mTOR pathway is relevant for vasculopathy, then the patients who get sirolimus should get better. They published their study last year in the New England Journal. So what they did, they identified these groups. These groups get biopsies anyways at 3 and 12 months, so they're ideal to follow up and look at the biopsies. And they get either sirolimus or other inhibitors. They found 37 patients who got the transplant and had antiphospholipid positive. 74 of them didn't have antiphospholipid, and they compared the groups. And among those 37 that had the antiphospholipid, they stratified them. 10 of them had sirolimus, and 27 had the different immune suppressants. Among the ones that got sirolimus, 70% did better and did not show any evidence of vasculopathy afterwards, while it's only 11% for the patients that had the syndrome and did not have the sirolimus treatment, but got the other immune suppressants. And it was a mix of immune suppressants. We see here the no antiphospholipid. We see in the biopsy after the transplant, the vessels look normal. In the non-sirolimus group, we see the trichrome stain showing a lot of connective tissue deposition. And the sirolimus treated group, it looks fine. We see the fibrous intimal hyperplasia, it's kind of gone with the sirolimus group. And we see that in the terms of functional GFR, the sirolimus treated group with the antiphospholipid is closer to the normal group that doesn't have the antiphospholipid syndrome. The ones that have it did worse if they did not get the sirolimus. And the only group that did worse over time, that was followed over 10 years, is the group that had the antiphospholipid and that had the non-sirolimus treatment. So what this suggests and supports strongly, and there's a lot of evidence in this paper, that the mTOR pathway is relevant for the vasculopathy pattern and the chronic long-term changes in terms of the vasculopathy. And this is only shown for the kidney, but we can speculate that this could be relevant for the brain as well in other organ systems. And so to put the pathogenesis overall, the antiphospholipid syndrome, when it's present, it causes thrombosis and it causes vasculopathy. And the mechanism is different. I'm trying to find my mouse. So yeah, the thrombosis, just to summarize, endothelial monocyte platelets, so many different pathways replicated over and over and over again. And then the vasculopathy, we don't know exactly what transmits the signal, but possibly those. And it goes down to the PI3 kinase, mTOR, to cause cell growth, cell proliferation, and survival. And if we use the sirolimus, maybe we can block this pathway. So this is something to keep in mind, and I'm sure there are some trials that are being designed for it towards this end. So to look at the pathology, as we said, there is chronic long-term changes. This is pathology that was identified in the brain. So we see fibrin thrombi of different stages. We see endothelial hyperplasia. We see fibrous webs. We don't see any inflammation. There are no cells in the vessel, so it's not like vasculitis. And we see that this suggests basically that there is endothelial injury. This is a very interesting case. It was published in '92. What it shows, this gentleman, 54, came in with multi-infarct dementia, and workup was negative. The angiography was negative. The TEE was negative. So they did a biopsy, And this is what the biopsy showed. Even though the big vessels didn't show anything on angiography, arteriography and angiography, this is what it showed hypercellular capillaries. It showed a lot of long-term vasculopathic-like changes, hyperplastic endothelium. And this happened in the capillary and some of the meningeal vessels, the medium to arterioles kind of vessels. We see that the elastic lamina is intact, but there's a lot of fibrin deposition and endothelial proliferation. So to diagnose this disease, I'm going to go briefly over those. I'm not going to go into the primary data just because we're kind of running out of time. But there was the initial criteria, proposed support criteria in 1999, and then they revised it and changed it for 2006. What they changed is two things. First, they include the anti-beta-2 glycoprotein antibody as part of the workup plan. So we usually we do send for it now. And the second thing they changed is the duration in between we repeat the test. Initially, it was 6 weeks, and then they made it 12 weeks. So the criteria as proposed, basically we need one clinical and we need one laboratory criteria. The clinical can be venous or arterial, or it can be a pregnancy morbidity, and they specify them. I'm not going to go into that. The laboratory criteria, either of those three tests has to be positive on repeat testing at 12 weeks. The lupus anticoagulant, the anticardiolipin, or the anti-beta-2 glycoprotein. But the most important thing they emphasize is the 12 weeks. So the natural question that comes to mind is, why do we need the 12 weeks? Why was it changed? Did any data support this transition from 6 to 12 weeks? And so I looked into that. And the answer in their manuscript that basically published the guidelines, this is what they say. They say persistent positivity is important. Before we chose 6 weeks because of concern of transient epiphenomenal antiphospholipid, false positive, so we made it 6 weeks. But we really don't know. We don't think, we're going to switch it to 12 weeks anyways. We don't think it's going to affect sensitivity, but we really don't know. This is only expert opinion. It's imperative that we do more studies. The only study they reference to support this claim for 12 weeks instead of 6 is this reference number 28 that I will show you like very brief slide, which I don't think it supports what they say. So like 1 for 1. It's important, but it's not like slam dunk. So this is a study that was done first only in kids that had lupus. 58 kids had lupus, and they had antiphospholipid testing on 2 occasions. So they checked them initially, and then they checked them in 12 weeks, and they saw the ones who tested positive, basically all of them, they saw how many thrombotic events happened eventually, and they tried to correlate those who got positive testing on repeat, persistent positive versus non-persistent, versus like just transient, to see if there's difference in the thrombotic events. The caveat here is that they only got, the N is only 58 for the total count, and only 7 had thrombotic events. And this reflects in their numbers. So the odds ratio they got, the lupus anticoagulant odds ratio for persistence is infinity. And the reason it's infinity because there's no kid that had thrombosis with negative lupus anticoagulant. So you have a 0 in the denominator, and you end up with infinity. The N is too small. And the second thing is that they compared persistent or transient. They couldn't compare transient alone odds ratio because they don't have enough N. The N is too low. So it's limited. And the third thing is that this study, what it really says is that the persistent positive antibody means we're at high risk of thrombosis. It doesn't mean that transient is not high risk. And it doesn't mean that it has to be 12 weeks. We don't know at 6 weeks. We don't know persistent at 4 weeks, 8 weeks, 16 weeks. Is that a factor? So it's totally random. So I would take this with a grain of salt when I'm managing those patients on the floor. It's a very dynamic, and I have, yeah.
Does anything know about the persistence of transient, let's say after infection, just the time course?
In terms of the time course?
Transient antibodies after.
Yeah, I did not find data. I tried to look for it. There's a lot. What I went through in all the reviews and all the primary articles, I did not see exactly. Most of the testing had happened like at 12 weeks after they reinforced the criteria, but there was no study that I could find that's aimed at testing serially after the infection to see how long the false positivity lasts. This very interesting variant, I want to talk about it for a couple of minutes. I've never seen one. We suspected it a couple of times, but it wasn't proven. It's the catastrophic antiphospholipid, and it's really catastrophic. So this is basically somebody who presents with a thrombotic storm. It's like DIC. It's like DIC or HIT, or somebody comes clotting everywhere. The presentation of these patients is related to the organ system involved, and we'll see which ones are usually involved, and they search the inflammatory response. So the pathology is thrombotic microangiopathy. So it's actually similar to the HELP and to the other syndromes that we see, like the HIT and DIC and all the stuff. We can definitely differentiate between them, but they tend to carry this kind of similar presentation. So there is a registry online that has 433 patients. This is just some epidemiology, not very relevant. 50% of the patients with antiphospholipid syndrome, their first presentation is CAPS, which is kind of devastating because we don't really suspect it initially. The other thing is infection is a huge trigger. 50% of those cases were triggered by infection. They had like an infection just before that. It's seen in when we draw anticoagulation, 11%, surgery, or tumors. Anything that causes vascular injury in a patient who has antiphospholipid antibody syndrome makes him at risk for CAPS. The other thing that's the organ system, so we see 35% basically of the cases, they had strokes, 50% had seizures. So there's a lot, coma, 6%. There's a lot of patients that because of this vasculopathic pattern, it presents like TTP. You don't necessarily need to see infarcts actually because of the endothelial dysfunction. It might be too small to see it. So, and it's associated with the different antibodies. The criteria to diagnose it are, you need 3 organs that are involved within less than 1 week. It has to be hyperacute and devastating to qualify. The antibodies have to be repeated at 6 weeks, so it's kind of diagnosed in retrospect, but if you suspect it, you have to treat for it. And then you have to exclude other diagnoses. They have definite and probable criteria. It's not very important. It's very sensitive, very specific, with good numbers, predictive values wise, if we use those criteria. What we see here, the differential diagnosis that they suggest and how to differentiate is TTP, HELP, sepsis, DIC, HIT, as you can expect. They kind of all present with this microangiopathic devastating thrombosis. It's triggered in different instances, it's triggered by different things. Like in TTP, it's the Adams 13, in HELP, it's something different. In sepsis, it's probably the endotoxin. In CAPS, it's the antiphospholipid syndrome. So there seemed to be like a theme, and I find this very, very interesting. What they recommend in this guideline publication is that suspected in a patient with multi-organ failure, consent for the other things to make sure you don't mix it up. The treatment may be a little bit different. So the antiphospholipid treatment, just before we go into the guideline, they, based on all the epidemiological data that we saw and that's available in the literature, they kind of rank the antibodies into highest risk and lower risk. The high risk, if lupus anticoagulant is positive, you consider this a high risk, and that will affect some of the management. If they have triple positivity, so if they have, like if I have a patient that's coming in with a stroke and I test them and they're positive for lupus anticoagulant, the risk of recurrent thrombosis is much higher if they have other antibodies that are positive. So this is a very strong sign that I would take into consideration. The other thing that will make them high risk is definitely if they have a repeat testing, that increases the risk. And if they have persistently elevated high titer anticoagulation. If it's intermittent, it's lower risk. So if you look at the treatment, IgG is definitely higher risk. It's definitely higher risk. IgA has, basically the data has debunked IgA as not necessarily relevant, but you see all kind of conflict. But the systematic reviews have ruled out IgA, and that's why it's not part of the criteria anymore. So if we look at the guidelines for treatment, I'm sorry, this is too small, but the most important thing that I got from this is that when I see somebody with antiphospholipid antibody positive, whether it's the syndrome or just one time, this is a risk factor. This is like smoking, maybe more potent than smoking. This is like hyperlipidemia. So these patients are at increased risk of thrombosis. So we need to risk stratify them and aggressively control her. There are other factors, the modifiable risk factors like diabetes, LDL, smoking, everything. And the second thing, if they're in the hospital, they need to be on anti-DVT prophylaxis because of their high risk. So here they go into the different primary prophylaxis. So these are somebody that comes in with antiphospholipid positive, but not a stroke. We don't deal with those usually because we don't test for it if they don't have a stroke. I'm not going to go into it. Same thing for patients who have SLE. We're not going to go. This is the interesting stuff that I want to just touch base on. This is secondary prophylaxis in patients who come in with documented antiphospholipid antibody syndrome, or they come in with one-time positive test, what do? So in the 4.1, this is somebody, they come in with arterial or venous thrombosis, and they have one testing that's positive. What do? The recommendation, grade 1C, which is low-quality evidence but strong recommendation, is that you treat them as if the antiphospholipid is negative. So you don't escalate, you don't consider them antiphospholipid anticoagulate syndrome. So if it's a stroke and the appropriate management would have been aspirin, so you do aspirin. If it is DVT, they need anticoagulation, you anticoagulate them. You don't treat them as antiphospholipid syndrome. If they have venous thrombosis, if they have DVT, you treat them with an INR goal 223, and they have good recommendation for that. What the controversy is that if they have antiphospholipid syndrome and they have a stroke, they recommend INR between 3 and 4, or Coumadin 2 to 3 plus aspirin, but they could not agree on it. And the reason, because they did not agree on it, they basically did not grade it. There's a lot of evidence that showed high rate of recurrence in patients with 2 to 3 INR. And the studies that did not show that have major flaws. So I would actually think, after reviewing the literature, don't have time to present it here, but I would anticoagulate somebody, not 3 to 4, but maybe I would consider Coumadin plus aspirin, and then if they have arterial stroke with documented antiphospholipid syndrome. And what they did not address, which is I think very important, is that what we see sometimes is that somebody coming in with one test that's positive and recurrent strokes. There is no evidence for that, and they don't recommend anything for that. Maybe we should anticoagulate them. I don't know. Anticoagulate them at least until the repeat comes back. Duration is basically infinity if it's documented. The CAPS treatment, the catastrophic treatment, what you do is you induce them with anticoagulation, glucocorticoids, Plex or IVIG, plus or minus rituximab. So see how high the mortality is. It's usually like 40% and maybe higher. But the patients, this is just from the registry, most of them got anticoagulation, glucocorticoids, Plex, IVIG. The patients who got rituximab did actually do well. So in this series 7, got rituximab, only one of them died. So the mortality rate was 14.3%. This is the best mortality rate among the different immunosuppressants. The follow-up on our patient.
Isn't rituximab too slow? Why should it work so
So
well?
yeah, exactly. So actually, I've seen it in NMDA patients where it acts right away. We had a patient on RDA last year where we treated them with IVIG, did not improve, Plex did not improve, and then we did rituximab with the expectation that it's going to take time, like up to 4 weeks for the antibodies to be depleted. But then the second day, the patient went from comatose to like speaking, following commands. I asked hematology about it and tried to look it up. There is a different mechanism other than just depleting the antibody that rituximab does that it's not clear to me.
The patient's steroids.
The patient had already gotten a lot of steroids.
So hematology in general is saying there is an acute effect of toxin. And they argue that even I think on our talk when they were talking about Plex techniques, they were actually advocating to introduce rituximab during Plex sessions and not wait until you're all done. And the argument is that there is an acute. So an acute is really mechanistic. So CD20 cells go to 0 immediately. So the co-regulators of the plasma cells and the cytokine milieu changes almost immediately. The antibody titers take 4 to 6 weeks.
Yeah.
But the
which is very interesting.
You know, the actual profile of immunogenic profile changes immediately.
So just a couple of slides for follow-up on what happened to our gentleman. The working diagnosis initially was vasculopathy from antiphospholipid. He got treated with rituximab because we really didn't know. So the decision was to treat him with immune suppress him and anticoagulate him, to treat him for both vasculitis and antiphospholipid technically. And he was followed, I didn't follow him up, but like his primary physician at MGH followed him with serial imaging, CTAs, MRIs. He was stable, switched to Coumadin, did well, and then was followed again. And then the repeat testing came back twice, and it was negative on both occasions. But that was after he got the rituximab. But so his diagnosis was switched in the chart to primary CNS vasculitis. And he's still on rituximab and anticoagulation, but the plan is to stop the Coumadin soon. And that has not happened. This is his testing. So he came in to us on 11/18. The repeat was on February. It was negative. All the beta-2 glycoprotein. It was repeated in April. It was negative. But the caveat to that, exactly. So this is the rituximab. He got the first dose on 12/26. Or actually, he got the first dose actually in November. And this is the CD20 count. It showed no cells on 12/26. So this test was when rituximab was effective. But there's a case report showing rituximab reduces the levels of the antibodies over time in patients with antiphospholipid syndrome. So could that have been like a false negative? However, a phase 2 trial looked at patients with antiphospholipid syndrome treated with rituximab, and they followed them over several months. And you see that the antibody, non-responsive means the antibody titer remained the same. Out of 10 patients that presented with antiphospholipid syndrome with positive antibodies treated with rituximab at 4 weeks, there was no change in the titer. At 16 weeks, no change. Like there was basically only partial response in 2. They still had the titer. In our guy, there was no detection. And this was about the N was like how much? Like it was like 12 or something patients. So it was remarkable. So it's not clear. So it could have been a true positive. The take-home message is it's always more complicated. And then think about antiphospholipid as a thrombotic factor. Last slide, sorry. And then think about the risk factors, stratify them. 12 weeks is not absolute. Always take the clinical picture into mind. So if it's recurrent strokes, just anticoagulate them. Risk of thrombosis correlates with the titers. Higher titer means higher risk, so I take that into account. Number of positive tests, if it's 1 versus 3, that's higher risk. And the different times. If I repeat it at 4 weeks and it's positive, that's high risk. And then the guidelines are a good starting point, but they're not absolute, so take it with a grain of salt. Thank you, guys. Sorry for keeping you late. Any questions?
No, as the crowd is coming in, I'll say it's the best talk I've heard on that subject. Period.
Thank you. That means a lot.
Very, very complicated.
Here's just a question while people are coming in.
Yeah, sure.
Chart, the phosphatidylserine was actually the best one for odds ratio, but it's not available, readily available. You can't get it in some cases. But do you read anything else about that? Because everybody's looking for more specific tests.
Yeah. So basically, there is actually a paper. I'm happy to send it to you.
This,
I just want to stop this. Just 1 second.